Acute angle closure glaucoma is an emergency condition and is characterized by a sudden increase in intraocular pressure. This can lead to symptoms such as severe eye pain, blurred vision, and nausea. So this poster aims to present the anatomical causes and management of the symptoms presented. So here we have a 56-year-old Inuit woman who had arrived at the emergency department with sudden onset of symptoms. These included red right eye with unilateral pain, blurred vision. She was seeing rainbow-colored halos. She had headache, nausea, and vomiting. During the examination, she had fixed midpoint dilated pupil of the right eye, and the cornea was hazy and cloudy. Using a split-lamp examination, they found that she had conjunctival vessels of the right eye were engorged, and the optic nerve was swollen of the right eye. The left eye was appearing normal. The intraocular pressure was elevated on the right eye, which was 65 millimeters of mercury, and for the left eye was normal. It was 20 millimeters of mercury. The patient has been taking cyclopentolate for 3 years and also has been taking duloxetine for 5 years. Anatomical causes. So if I can direct your attention to the left of figure 1a, now we're going to talk about how the eye normally functions. So the eye is filled with a fluid called the aqueous humor, which is produced primarily in the ciliary bodies, which are the ring-shaped structures located behind the iris. The ciliary bodies contain ciliary processes, which are folds of epithelial tissue rich in capillaries. These processes secrete aqueous humor into the posterior chamber of the eye. The posterior chamber is the space between the iris and the lens. Aqueous humor produced by the ciliary processes flow into the posterior chamber. The pupil is the aperture in the center of the iris that regulates the amount of light entering the eye. Aqueous humor passes through the pupil from the posterior chamber into the anterior chamber. The anterior chamber is the space between the iris and the cornea. Aqueous humor circulates within the anterior chamber, providing nutrients to the avascular structures of the cornea and the lens. From there, it passes towards the trabecular meshwork, which is better visualized in the right of figure 1a. The trabecular meshwork is a spongy tissue located at the angle between the iris and the cornea. Aqueous humor exits the eye through the trabecular meshwork via filtration process. Schlemm's canal, a circular channel located adjacent to the trabecular meshwork, collects the aqueous humor. Collector channels, also known as aqueous veins, drains aqueous humor from the Schlemm's canal into the episcleral venous system. From the episcleral venous system, aqueous humor eventually enters the systemic circulation. The production and drainage of the aqueous humor are tightly regulated to maintain the intraocular pressure within the normal range. Now, if I can direct your attention to the left of figure 1a, acute angle closure glaucoma is primarily caused by the narrowing or closure of the anterior chamber angle, affecting the ability of the aqueous humor to be drained out of the eye. This closure can result from various anatomical factors, including anatomically narrow angles due to variations in iris size or lens position, exacerbated by conditions like pupillary block, where the pupil obstructs aqueous humor flow, age-related changes in the lens, iris thickness, and systemic factors such as genetics can further contribute to angle closure. Now, if I can direct your attention to Table 1. Here, each of the presented symptoms in the case and the anatomical causes are labeled in the figures above. So you can trace where in the eye the dysfunction can lead to the symptom. This will help to develop the differential diagnosis later on. So starting off with the unilateral pain of the eye, the redness and the pain of the eye are indicative of conjunctival vessels engorgements and increased pressure within the eye, respectively. This is marked by the location of number 1 in figure 1a and b. These symptoms are primarily caused by the blockage of the aqueous humor outflow, leading to elevated IPO, which is intraocular pressure, and subsequent ocular tissue inflammation. Number 2 indicates the anatomical cause of blurred vision, which arises due to corneal edema caused by an increase in intraocular pressure, which alters the reflective properties of the cornea, leading to visual distortions. This is why number 2 is in front of the cornea to represent corneal edema. Number 3 represents why the eye became red. This is closely related to the unilateral pain of the eye caused by the elevated IOP followed by the ocular tissue inflammation. Number 4 represents seeing rainbow-colored halos, which has occurred due to corneal edema and distortion causing light to be scattered onto the cornea and produces spectral colors. Number 5 represents headache. So if you look at figure 1b, this represents the innervations of the eye. If you look closely, you can see the ophthalmic nerve. As we have learned in Module 7a, the ophthalmic nerve, a branch of the trigeminal nerve, CN5, primarily provides sensory innervations to the eye and parts of the nasal cavity above the palpebral fissure, including parts of the forehead and scalp. The ophthalmic nerve leaves the cranial cavity via the orbital fissure to transmit sensory information related to pain, touch, temperature from these regions back to the brain. Therefore, a headache is a common symptom due to the inflammation that was perceived before. Additionally, number 6 represents nausea and vomiting. Headache, nausea, and vomiting can be the results of increased IOP, causing compression of the optic nerve and subsequent ischemia. Targeting this can target pain pathways and autonomic responses. So this is why you can see number 5 and number 6 are close to the optic nerve in the left of figure 1a. Lastly, if you look at the right of figure 1a, there are short and long ciliary nerves which carry sensory impulses to the ciliary ganglion, further enforcing the feeling of nausea and vomiting. This pathway is clear in figure 1b. Differential diagnosis. So here, if I can direct your attention to Table 2, we compare the differential diagnoses based on symptoms and causes to make it easier to identify and pick the right diagnosis. False means that the symptom is not typically seen in this diagnosis, while true means that it's typically seen in this diagnosis. The three differential diagnoses are primarily open-angle glaucoma, ocular ischemic syndrome, and acute angle closure glaucoma. Primarily open-angle glaucoma is one of the most common types of glaucomas characterized by the gradual onset of chronic progression. It often presents with symptoms such as blurred vision, elevated intraocular pressure. As you can see from the table, symptoms such as redness of the eye, rainbow-colored halos, nausea, and vomiting are not symptoms of primarily open-angle glaucoma. Additionally, the acute nature of the condition does not typically align with this condition. If you look at the second column, ocular ischemic syndrome is a rare condition characterized by severe ocular hypofusion leading to ischemia of the anterior segments structures. Symptoms may include blurred vision, headache, and ocular pain. Now, considering the severity of symptoms and the potential vascular involvement, OIS was included as differential diagnosis to explore the possibility of ischemic ocular pathology. However, OIS is a chronic condition and is not acute. Lastly, acute angle closure glaucoma is the correct diagnosis for this patient. This is because it is characterized by a sudden increase in the intraocular pressure due to the blockage of aqueous humor outflow. Its symptoms include a red, painful eye, blurred vision marked by elevated IOP, closely matching those with the patient. Furthermore, the physical examination findings such as fixed midpoint dilated pupil and ingorged conjunctival vessels are typical of the acute angle closure glaucoma. Moreover, the medications the patient was taking, which are cyclopentolate and duloxetine, are the two of the medications that can lead to acute angle closure glaucoma due to the exacerbation of the pupillary block by dilating the pupil. Additionally, acute angle closure glaucoma typically happens between the ages of 55 and 65. It is 2 to 4 times more likely to happen to females than males, and certain ethnicities such as Inuit individuals are at higher risks of developing the disease due to the anatomy of the eye. Therefore, because of these associations, acute angle closure glaucoma is clearly the most likely diagnosis. Management plan. The short-term management, upon diagnosis, the immediate focus is on reducing the intraocular pressure to elevate the symptoms and prevent further damage. This involves the administration of intravenous mannitol ranging from 1 to 2 grams per kilogram of body weight, along with acetazolamide, a dose of 500 milligrams. Additionally, topical pilocarine is instilled once the IOP falls below the 40 milligrams, typically administered to 1 to 2% solutions with 1 drop every 15 minutes for 2 doses. The next stage is after acute episode. Here, attention shifts to preventing future attacks. Laser peripheral iridotomy is performed within 24 to 48 hours to create a small hole in the iris. This will create a path for the aqueous humor to drain from, reducing the risk of recurrence. If the LPI was unfeasible or unsuccessful, surgical iridotomy may be considered. Next is a long-term management. This is continued monitoring is essential for long-term prevention of vision. Optic coherence tomography imaging is conducted within 1 to 2 weeks post-treatment to assess the structural integrity. Also, there's the regular monitoring of IOP every 3 to 6 months to allow every detection of recurrence or progression, ensuring the timely intervention. This is evidence-based treatment timeline for acute angle closure glaucoma. I hope you enjoyed the poster. Thank you so much.